All right, welcome everyone. We're very excited about tonight's topic, caring for your child's heart from sports safety to lifelong health. We have an incredible special guest, Dr. Sean Connolly, tonight, who will be speaking from the incredible Nemours Children's Health Network. And I want to take a moment just to introduce myself. My name is Michael Rouse. I'm the executive director and co-founder of ESF Summer Camps. My experience with Nemours started around 4 years ago when my little girl, Naomi Grace, was born. And we met some of the most incredible doctors and specialists and nurses who took care of our little girl as we were kind of on her journey through some health challenges. And we were just captivated by the amount of care and love and experience that the Nemours team put forth towards our child, plus many other children I saw throughout the course of the several months that we were at Nemours. And as a result, we became instant fans. And we've been very fortunate to create a relationship where we're able to have these special webinars for all of our ESF families. And so tonight's special guest is Dr. Sean Connolly, who is going to be speaking about some really incredible information for all of us who are parents to know about cardiology and what is so important about our children's hearts and how do they develop and how do they grow to be healthy humans as they become adults in life. And so I want to take a moment and introduce Dr. Sean Connolly. Thank you, Dr. Connolly, for coming. Tonight's session, for all of you who have tuned in, you can see us, but we can't see you. So please realize that you're on mute, but please use the Q&A box of this webinar to ask any questions that you have throughout the course of the evening. Share your questions as they arise. We will do our best to address as many questions tonight as we can. As your questions come in, there's a high chance that if you are asking that question, there's about 50 other people that are asking that, thinking about that same type of question. So feel free to slow us down as we're going through tonight's webinar. This presentation is being recorded and will be emailed to everyone who RSVP'd after tonight's event. And like I said, we're really excited about Dr. Sean Connolly, who is part of the dream team at Nemours. Welcome, Dr. Sean Connolly.
Michael, thank you so much. Thank you for the introduction. And, I echo what you said. Nemours is a wonderful place. I've been there for about 4.5 years now as a pediatric cardiologist, and I was there for about 3 years before as a resident. I did my cardiology training at Lurie Children's Northwestern in Chicago, but currently I'm an assistant professor of pediatric cardiology at Nemours and through Jefferson University. Clinically, and we'll talk about some of these because some of these topics tonight, I think are really just some of the ones that I'm most interested in, but I do a lot of work helping to take care of the patients who are admitted to our hospital, whether that's for operations or for other reasons. I do a lot of general outpatient cardiology and preventive cardiology. And I'm importantly, and it'll relevant for tonight's talk, I'm the medical director for what's called Project Adam, which we're an affiliate of, and which you'll learn a little bit about in tonight's talk, where we go around really in schools all throughout the state of Delaware and provide education resources and training to prepare for sudden cardiac arrest events. I do work through the American Heart Association. I do research in this field as well. And I'm currently excited to be involved in the executive leadership committee for the AHA's Go Red for Women campaign for this year to raise funds and money to really help and support our heart health in particularly in women throughout the state of Delaware. And so this is a great opportunity. Thank you for inviting me to your wonderful organization. I love it. When I was first sort of proposed and offered to kind of talk tonight, the general concept was to talk about heart health, and it was actually a great sort of way to just throw that to a pediatric cardiologist. What does that mean in our world? And I just want to use a moment and one slide here while it is still February and we are still in Heart Month, which is we do 12 months a year, but is a particular time where everyone in the country really thinks about heart health and what does that mean. And for pediatric cardiologists, the majority of what we do is think about and take care of individuals and children and families who are affected by congenital heart disease. And so congenital heart disease is when an individual is born with an abnormality of the muscle of the heart. And this is the most common birth defect. It happens in about 1 in 100 individuals. And it really runs the spectrum of sort of how it affects an individual. And so this is a significant portion of what a pediatric cardiologist does. And maybe some of you in the audience most likely know somebody, or family member, or a neighbor, or someone else who's had congenital heart disease. This is certainly a topic, or many topics unto itself. It is not the focus explicitly of tonight's talk, though. And tonight I wanted to talk about heart health from a big, broader sort of concept. And I really wanted to think about it from two perspectives. So what does heart health mean to me? As I kind of thought about this, I think the first and overarching theme here is that as adults who are responsible for our children, whether that's you're a parent, or a caregiver, or a cardiologist, or a pediatrician, our job is to deliver our kids through these stages of life and get them to adulthood, right? And we want to do that safely. And we want to do that safely in such a way that they avoid having tragic events, right? With particularly cardiac arrest events. And we'll talk a lot about that tonight. And two, we want to deliver them to adulthood with full stores of what we call cardiovascular health. And that might seem like a very broad or nebulous sort of term. What does cardiovascular health mean? That's sort of defining it, heart health, by calling it heart health. But I'll tell you the very specific nature of what I mean by cardiovascular health, and it's this concept of life's essential 8. And so we want to deliver our kids to adulthood safely and with full stores of cardiovascular health. And we'll talk about all of these things a little bit tonight. We're going to specifically talk about the pre-participation heart screen, and how you as a parent or as a family member can identify potential things that in your children and your child that might require further evaluation. How your doctor can do this as well, because you are an advocate for your child, and so bringing this information to your child's pediatrician is important. We want to make sure that they're safe for physical activity, right? Physical activity is such an important component of life in the child. And so we want to make sure that they're doing this safely. We're going to talk a decent amount as well about what has become a passion for me in my work at Nemours and across the country, related to preparing in the event that a cardiac arrest event happens, which unfortunately they happen. And so how do we become better as a society in terms of understanding and practicing CPR and AED use and cardiac emergency response plans? And so we're going to talk about that. And then we're going to pivot away from some of these ideas and look at the 8 essential factors that support lifelong heart health in children and help them thrive into adulthood. So,
Dr.
Yeah.
Question already has popped up from a couple parents. That CHD statistic is pretty shocking. And one question from one of our parents was, when your child is born with this, that statistic, are you told as a parent that your child has CHD?
So I would say that 1 out of 100 is actually probably an underestimate, to be honest. And the question is a great one. The majority of congenital heart disease, I want to be careful so that I say this. Again, I think it runs a spectrum in terms of how much it affects a child and when it affects a child. It's hard to say one size fits all. A lot of the particularly significant types of congenital heart disease that we would see in a hospital in a baby, so ones that require heart surgery, for instance, in the first year of life, the majority of these in 2025 are discovered during prenatal screening through the OBGYN. That being said, there unfortunately are instances where that's not the case, and this usually becomes apparent in the first hours to days of life. There are other types of congenital heart disease that are lower down on the spectrum of sort of how it's going to affect a child right away, that may not be understood right away. But once somebody, this is why all these visits with pediatricians are important, particularly in the early stages, weeks, months of life, is that some of these things aren't identifiable at birth, but that become apparent by physical exam and by other such things. And so when that's the case, yes, families will be told this is something that then needs further evaluation. Great question.
Great, thank you.
So in an important thing to understand, sort of going forward is what is the difference between a heart attack and cardiac arrest? And what is it? What is a heart attack and what is cardiac arrest? And I imagine everyone has these general terms and have used them in life. I want to kind of give it to you really as I would think about it. There are differences, right? A heart attack and a cardiac arrest are two different things. And a heart attack is a plumbing issue, so to speak. The heart is a muscle, and its job is to pump blood to the rest of the body. And that muscle itself needs to have oxygen-rich blood to function itself, right? And so these blood vessels that you see on the left side that an arrow is pointing to in red here, these are the coronary arteries. And these are the blood vessels that supply that heart muscle itself with oxygen-rich blood. So every time the heart relaxes, after it's squeezed, it relaxes, and those blood vessels fill with oxygen-rich blood. They give that muscle of the heart what it needs. A heart attack is when you get a blockage of one of those big arteries. And so on the right side, you see this dead cardiac muscle. And so if that muscle isn't getting that oxygen-rich blood that it needs, that muscle and that tissue sort of beyond that begin to die, and they don't function like they should. And that heart muscle can no longer pump and squeeze like it needs to deliver oxygen to our brain and to our rest of our body. And it can promote an arrhythmia. So that's a heart attack. I think heart attack plumbing, heart attacks typically in older individuals, right? I think 35 or older, there are certain instances and things that kind of bring that number down in very rare circumstances. For the most part, these happen to older individuals. It's one of the things that we talk about later in the talk about how we can improve our children's chances of not having heart attacks or having them much later in life than they would otherwise. So keep it in mind. Cardiac arrest, on the other hand, this is more of an electrical conduction system problem. And so again, the heart is a muscle, but what drives that muscle to beat is what we think of as an electrical conduction system. And so on the left, we see the normal heartbeat, and we see these specialized set of cells that live up in the top part of the heart, and it sends a signal down the muscle, down the top part, down to the bottom, and it tells these chambers to squeeze and provide that blood pressure that our body and our brain and our heart need to survive. And so that's a typical thing that happens. So if we're sitting here on a Monday night after work, our heart rates were coming down from the day. Our heart rates might be somewhere between 60, 70, 80 beats per minute. And that's all driven by the normal electrical conduction system. Cardiac arrest happens when that electrical conduction system fails us in some way, and when no longer can that drive the squeeze of the heart. And the most common sort of end pathway by which that happens is we call ventricular fibrillation. And so it's this concept where all these little stars are shooting off. These are abnormal signals from the bottom chamber of the heart that never really propagate a meaningful outflow of blood from the heart to the rest of the body. And so cardiac arrest, unfortunately, is something that can happen at any age. And again, it's an electrical conduction system problem. And so as pediatricians and people who are seeing kids, well, certainly, again, not necessarily in this talk thinking about congenital heart disease, but thinking about how do we keep our kids safe and get them to adulthood safely and doing all the things that they want to do. We should really be thinking about, particularly when we're thinking about the heart, is who may be at risk for this. This is a needle in the haystack type scenario, but who might be at risk for cardiac arrest? How do we prevent that? How do we identify them and get them to a pediatric cardiologist or someone who can sort of dig a little bit deeper into it? And that's sort of the general concept here. I think when we get to what I imagine many of you who have children, which is, I imagine the majority of you here on the call tonight, go to this pre-participation physical. And so this usually happens in a mad rush at the middle of the end of summer before fall sports start, and everybody needs to have their physical done. And this is looking at this is sort of the concept that happens within all states, and usually there's some slight subtle differences, but the general concepts are the same. And while they're looking for overall health for sports, one of the main focuses is on heart health, and specifically identifying individuals who may be at risk for a heart event, which really is a cardiac arrest event, is really what we should be talking about it as. It's not just for people who play sports, and the American Academy of Pediatrics and the way that pediatricians will think about this at the onset is really screening everybody. And this should happen during your routine well child visits and at least every 3 years. And certainly as, your child goes into middle, junior high school, these are good opportunities to like revisit some of these things. And you as parents, listen to your children as you do, and like think about, have you ever seen anything like this? Is this ever anything? Or even your child's friends or anybody that you're sort of in your community, have they ever fainted? Have they passed out? Do they had unexplained seizure, particularly during like response to a sudden loud noise? This brings to mind a very specific type of arrhythmia. Has the child ever had exercise related chest pain or shortness of breath? Has anyone in the family or distant relatives died of heart problems or had unexpected sudden death before the age of 50? And then this fourth question is just very specific things. And usually family members know about this. Like if they have a family member who has hypertrophic cardiomyopathy, Marfan syndrome, arrhythmogenic cardiomyopathies, long QT syndrome, Brugada syndrome, CPVT, which is short for catecholaminergic polymorphic ventricular tachycardia. Again, these are things that typically in families, while these are overall in the population rare, usually families would know about these, but these are important things to know, for our children who may not have been diagnosed with this, but may be at risk. So these are some general questions or things for you to think about or to bring to your pediatrician when you're going to these well-child visits, to kind of think about, is my child safe to continue to do this? And remember, most of the time, yes, absolutely. And we want them to be active, but we also want to make sure we're going through the proper channels and screening. When it comes specifically to
So, doctor, what you're saying is, just so I'm clear, you're basically saying that last slide is questions for us as parents. Like if we've experienced this, because what you're saying is if we've experienced this, that we should let our children's doctors know this, because it
I'm
could.
sorry, Michael. Thank you for letting me clarify. No, this is for our children.
Got it.
These are questions for our children. Now, in some instances, with regards to family history stuff, this might be for us as well, in terms of thinking about this, in our family and how that may relate to our children.
Okay, great. Thank you.
And as we move on, the AHA has a 14-point screen, and this includes physical exam findings. And this might be what your pediatrician is doing leading up to a pre-participation physical. These questions are, first of all, you'd see all these questions. Many of you might be sitting here and going, I think my child or myself has had a flutter in his chest before. How do I know if that's normal or not normal? The purpose certainly is to cast a wide net and to have a low level of suspicion that there could be something that needs more investigation. And there's a purpose to that because, we want to identify this early, right? And we don't want to put people through testing that isn't necessary. But these questions are certainly get us to the small number of individuals who might be affected by this. And so when we're thinking about sports physicals, many of these questions come up, and a lot of these are the same. I think this kind of adds a few other elements that I think are important. Elevated blood pressure, in particular, is one in which sometimes requires further evaluation. Thinking about, are you short of breath more than your friends during exercise? Are you having that heart fluttering? And the reality is it's sometimes challenging, especially just with questions, or to distinguish between what are often, benign feelings of heart palpitations, or feeling your heart beating, or feeling a little lightheaded because you're dehydrated, or deconditioned to some extent, as it's maybe the beginning of a new sports season and haven't been as active over the summer. And so it's hard to distinguish between that and a true potential risk for heart related events. And so these are just really important questions that your pediatrician would ask, or that you would think about, and that often then lead to a referral to a pediatric cardiologist. And here's an idea of what maybe goes on at a pediatric cardiology office visit. It starts with an EKG.
Electrocardiogram. It's sometimes called ECG. An EKG checks how your heart is beating. During the test, you won't feel a thing. Here's what happens. Your skin will be cleaned with an alcohol wipe. Little stickers are placed on your arms, legs, and chest. Then, wires are clipped onto each sticker. This doesn't hurt. Next, you'll be asked to hold still and breathe normally. On a monitor, you'll be able to see what your heartbeat looks like. After a few minutes, the test is over and all of the stickers will be taken off.
So an EKG is a really helpful tool. Obviously, as you see, this is painless and simple, and it gives us a lot of information about the electrical conduction system part of the heart. It can help detect arrhythmias and abnormal heart muscles, and is really universal in any sort of pediatric cardiac visit. Um, Echocardiogram is an ultrasound of the heart, and I'll kind of play this clip a little bit, and you'll see Lehia here from Nemours performing an ultrasound of the heart, which looks very similar, as you would imagine, to any ultrasound you've seen before. But this is really looking at the structure of the heart. So an echocardiogram is what would define and diagnose congenital heart disease, but it would also help us understand about the heart muscle itself. And so individuals over time can develop abnormal hearts if they are prone to it, often through genetics, where the heart muscle is really thick or abnormal and the squeeze is abnormal. And so an echocardiogram can tell us that. And this is also a really widely used tool in a pediatric cardiology visit when we get referrals from pediatricians related to some, something in the story, something in the family history, something that a child is experiencing or describing that really believes that warrants a little bit further evaluation. And so an echocardiogram takes about 30 minutes or so, and again, is generally pretty painless. We do these often, every day, hundreds of times a month. And we look at these and read these ourselves and come and explain the results ultimately to a family.
Doctor, you're seeing some products out on the market today, and I'm not too. It's where you put two fingers on it, and I don't know if it's an EKG.
Yeah,
or
great.
Or,
I know what you mean. I won't name any specific names, but you're right. There are several brands of these heart rate monitors. I would even maybe be outraged about one of them. An Apple Watch is a form of that in a sense, but I think what you're talking about are ones that maybe get more granular in terms of what they're diagnosing.
Yeah.
I'm not opposed to those. I think that I caution to some extent against using them. I have had numerous referrals for an individual, often a teenager with an Apple Watch, who's just worried about that number that he or she sees all the time. But it's always it's normal. It's not a problem. But they're worried about the numbers. It says that it's 185. Is that a problem? And I'm like, well, how do you feel? And they're fine. I don't feel a problem at all. So it's okay. We're happy to clear that up and provide that reassurance. But you missed a half a day of school for that. But the monitors that you're kind of talking about, they can be helpful. I think that sometimes they are used as a surrogate to what we call Holter monitor. And for me, to diagnose an arrhythmia, truly diagnose it, I want to see it on an EKG, in an ER if it needs be, or on what's a Holter monitor, which is really the gold standard in terms of heart rate monitors. But those aren't bad, and at some points they might help distinguish, infrequent arrhythmias, because there are some instances where children are having often not the life-threatening kind, but other types of arrhythmias that just happen like once every 3 months. And it's hard to capture that on a Holter monitor, because who wants to wear a Holter monitor for 3 months? But those are decent tools to do that.
Okay, great. Thank you.
Another thing, Holter monitors was actually a great one to bring up. I will put that on the next iteration of this, but exercise stress tests are another test that's unique to the pediatric cardiologist, where in some instances we are having the patient come and actually run on a treadmill or ride a stationary bicycle to increase that heart rate, to get it up as high as you can, get the blood pressure high, get their adrenaline going. And there are some very rare forms of arrhythmias that are dangerous and that present only in that peak exercise like this, and that aren't visible or noticeable on a baseline EKG, certainly not on an echocardiogram. And this is one test where that benefits. I think this test also helps a lot of times with reassurance and saying, look, we got your heart rate up to 205 beats. You got your heart rate up to 205 beats per minute by, spiking really hard. You're in great shape. You felt awesome. The EKG looked normal throughout. The blood pressure felt normal throughout. Like, you have a healthy heart, right? So these are some of the tests that we would do as pediatric cardiologists to help identify, sort of as we're going further beyond just that screening stage, to really trying to tease out and identify who might really have risk for cardiac arrest, right? If Michael doesn't have a question here, we're gonna shift gears just to the next topic.
Sure. Yeah, Doctor, we so far we've had full engagement. I think what the couple questions we've had is really the preventative side, which I know you're about to get into. So that's why we're going to hold off on some of those questions.
Well, so to me, the prevention side is about screening and identifying. And this is one great way. These are the ways that we can do this, right? I think it's through recognizing that the majority of our children like this are healthy and active and asymptomatic, so to speak. But in those kids who report those symptoms on those slides that we had shown before, they often require some other evaluation, whether that's through the pediatrician alone or through a pediatric cardiologist to dig a little bit deeper and use some of these other tools. I think that where I go next with this, and where a lot of us, in this world go, is that there is no perfect screening method for these types of events. These are generally very rare, but we don't want to prevent all of them, or at least be able to save lives of individuals who may have something like this happen. Because whenever it happens, without a doubt, it is a tragedy, and we have a lot to improve upon in our society, in the places where we spend a lot of time, in particular schools, youth sports leagues, camps, in order to prepare us for a cardiac arrest event ever happening. And so a lot of the work that I do sort of through the American Heart Association and through Project Adam, pause this for a second, is in cardiac emergency response preparedness, which can be boiled down in a sense to CPR, AED training, and things like this. Before we show this video of Claire Crawford, which was really inspiring, and it drove a lot of, when I first saw this, I just remember being like, this is something I need to be involved in and help with. I remember, in 1990, so I was about 8 years old, and I was a big college basketball fan and was watching. I vaguely remember this and just knew I watched all the games then. And Loyola Marymount was the #1 team in the country, and Hank Gathers was the all-star player for the team. And on national television, in a game sort of leading up to the NCAA tournament, he collapsed on the court on national television, and he died. He had cardiac arrest on the court. And I remember this being really sad, and people talking about it. Certainly didn't know any of the details. Obviously years later now, and in the work that I do now, having learned a lot more about his particular event, because it was such a thing at the time, is that it took 6 minutes for CPR to get started. It wasn't in the culture to start CPR right away. The AED was in the athletic director's office, which was down the hall from where the event was happening. And they took him to the back into the locker room to start CPR. And this, we don't want that to ever happen again. I think that the part of what we try to do is educate about things like hands-only CPR and using AEDs that we'll talk a little bit about today, because it is such an important way and ability to save a life. And so Claire Crawford will watch this video, and I hope that you find some inspiration from this as well. This was an amazing response and life saved.
Had 2 games that night. I was in a lot of pain, which I was used to because I've been playing in pain the entire season.
You could tell that she was laboring somewhat,
But Claire just has the heart of a champion, and she's just going to keep playing.
When I was sitting at the scorer's table, keeping score for the game, I just heard a loud thud.
I think we just started yelling for help.
Yelling 911. Feeling of helplessness.
And it was very quickly that there was people there with us, very quickly.
she fell about right here. Starting back in 2006, our school got the first AED. As part of that training, we would come together and we would have drills unannounced. Because of the code blue drills, there were some things that were just instinctual to me. The AED is literally right outside of those doors. Go grab the AED, bring it back, and get to work.
You really can't describe
Yeah,
just the fear you have going through your mind.
it really looks like they were running a drill, but it was so quickly that people were to Claire and that they were taking care of her, and it was amazing.
She was in VFib, And so the only thing that would bring her heart back into a viable rhythm was to have a shot. The AED was needed in order to bring her back to life.
It's complete joy seeing her revived.
I'm just really thankful, and I feel really blessed that this is where I was chosen to go to school at, and just really thankful. We know that God created her, and He knew about this moment before it happened, and He knew who would be here and what the outcome would be, and then what we would be responsible to do going forward to share her story. Well, we wouldn't let our child participate in a sport anywhere at this point if there wasn't an AED machine accessible. Waiting until someone's gone is not a good time.
Inspiring. Wow. Inspiring.
It's unbelievable. And there are, that family in this particular video just like it explains the story. As you would imagine, there are many other stories that are similar to this, and there are many more, unfortunately, that ended the wrong way. And I think if you're, I think probably the biggest take home point I could imagine as a parent on this call would be that if your child's school does not have a cardiac emergency response plan, or you don't know if they do, that you can do that. You can be the leader to kind of bring that to your child's school. And I'll give you some certainly some ways to do that. But my suggestion would be to go on the Project Adam website to learn about the opportunities to work with your local children's hospital and affiliate Project Adam to kind of get this into schools.
Yeah, and I would just encourage families, with your local schools, and also if ESF isn't your choice of camp, to ask. For instance, at ESF, we have an RN at all times while camp is open. We have AEDs circulated at the campsite, and our director leadership team has first response experience on Red Cross certified. So important, and so we encourage you to talk to your schools, to your camps, just to make sure that your child's always out of harm's way should this unfortunate incident ever happen.
Yeah, that's great. That's awesome. I completely agree. In general, in the United States, there's about 350,000 out of hospital cardiac arrest events that occur. This includes adults. In children, the number that we use and that we estimate is about 7 to 23,000, which is a pretty wide range. Unfortunately, there isn't really a national registry that kind of collects this data overall, and so we're left with various registry studies that kind of give us this broad range. But overall, we know it happens. 7,000 even in a year seems like a lot, and 23,000 certainly is more than and requires us to be prepared. About 1 in 300 youth have some undetected condition that puts them at risk for sudden cardiac arrest. And I think if in effect, if you don't believe that anyone's at risk for sudden cardiac arrest from an inherent sort of abnormality of the heart muscle, you look at Damar Hamlin, who was screened beyond belief for everything and didn't have any underlying condition, but who on that fateful game in January of 2023 was sort of hit in the chest right at the wrong time and had what's called commotio cordis, which is agitation or disruption of the heart, and hit it right at that the wrong part of that electrical conduction system signal going down, which just shocked the whole thing and put it into ventricular fibrillation. And he had cardiac arrest, and his life was saved by like just an unbelievable A+ response that a team like the Buffalo Bills and in the NFL can have. And our goal, in many respects, is to be able to replicate that type of response everywhere. And so it really starts with the lay rescuer, right? This is everybody. This is like all of us. This is even our first graders who are able to recognize that something's wrong, maybe call 911 or maybe get help and even start CPR. And so those of us on this call, the things that can save a life are recognizing cardiac arrest, calling 911, starting CPR, and if you're interested in learning more, they're happy to kind of give you some direction as to where you can go to do that. I would start with what's called hands-only CPR, and we're going to talk about that, and using an AED. And these things, seemingly simple things, absolutely are what are needed to save lives, and they don't happen as frequently as we think they should. Watch.
I'm John Dresden.
When it comes to recognizing sudden cardiac arrest, this is one of the best videos out there, and this is going to talk a little bit about recognizing sudden cardiac arrest, particularly in athletes. Jonathan Dresner is one of the leaders in this field, particularly in sports, cardiac arrest in youth and in young adults. And so we'll watch this video. It should be about 2 minutes, and we'll move on.
Director of the UW Medicine Center for Sports Cardiology. And in the next 100 seconds, I want to show you how to recognize sudden cardiac arrest in an athlete.
He can be seen coming out of a timeout huddle, his head dropping. He stumbles, then alarmingly, he falls face first.
Here you see Keontae head drop, stumble, sudden collapse. This is what sudden cardiac arrest in an athlete looks like.
And collapses, just like Hamlin did in sports from football to lacrosse to baseball.
Mark Vivian Foe shows all the signs of sudden cardiac arrest. Continue breathing after collapse. Eyes open and rolled back. The face of sudden cardiac arrest. For Nemours, after his arrest, his arms go up with seizure-like activity. For Christian Eriksen, sudden collapse, also unresponsive, eyes open, brief seizure activity in his leg. This is sudden cardiac arrest.
Been there, but that's not a good look at all.
With Claire, a dramatic episode, collapse with seizure-like activity in the arms, an amazing emergency response. Call for help, someone go get the AED. Remember, in a collapsed athlete that is unresponsive to verbal stimuli and a shoulder tap, you must assume it's sudden cardiac arrest. Call for help, start chest compressions, get the AED. Anyone can save a life.
Dr. Connolly, the one thing that I saw in that video, which is heart wrenching, is the victim is breathing heavily, rolling of the eyes. I would have first thought it was a seizure.
Yeah.
What do you do in that situation?
So I think that maybe I went beyond his slide. If we focus at the end of his the very end of this presentation in that video, he puts out an algorithm that effectively says if you aren't sure and somebody's down like that, we start CPR. That the default is not seizure, but the default is cardiac arrest. I agree with you. That is a challenging thing to do, and for someone walking by or being in the stands to not to be sort of tasked with or feel like they have the responsibility of distinguishing between a seizure and a cardiac arrest. There are several things that are overlapping in these, and so the default is to think this is probably cardiac arrest, and as you're to that individual that you're starting CPR. As and realizing that that's the more likely scenario.
Okay.
And to that point, unfortunately, CPR is really not, despite it being something that I think we all have heard about, and certainly, depending on what you do for a living, you may be certified in it. But overall, there's only about 18% of the population are currently trained in CPR. And the last that I had seen was about 4 to 6% of the population are learning CPR a year. So these are still low numbers, and in individuals who have a cardiac arrest event, only about 40% of the time is CPR being started on those individuals, and that's in some of the best case scenarios, like in places like Seattle, Washington, for instance, or other areas that have been studied. Certainly in other parts of the country, that percentage is significantly lower, and so what we really promote is the concept of hands-only CPR. So getting your phone out, calling it, and starting to push hard and push fast at 100, 120 beats per minute. Anyone who's done CPR or taken CPR classes would probably understand what this slide is about. I'm not just a big, Beyonce or Shakira fan, although they do get played often in the house with my 2 young daughters. The Bee Gees not so much, but really quick,
a teen or adult suddenly
hands-only
collapse, it is
CPR.
important to act fast. Helping to save a life is easier than you might think. Just start hands-only CPR. The first step is to ask someone to call 911 and to get an AED, or call 911 yourself and put your phone on speaker mode so the operator can assist you. Then get directly over the victim. Put the heel of one hand in the center of the chest and put your other hand on top of the first. Then push hard and fast in the center of the chest until help arrives. It's important to push getting 100 to 120 compressions per minute, which is about the same tempo as the song Staying Alive, or the rate of music you're listening to right now. Let's hope you never have to use hands-on CPR, but
All right, so you get the idea, and I encourage anyone to go onto the American Heart Association website and learn more. AEDs, survival increases by at least 25% with the use of an AED, and in individuals who are in a shockable rhythm, which the AED guides you through, it increases the survival exponentially more. I think the thing that I would say about AEDs is that there was a time, and maybe even now in certain places, where a sign says for professional use only. That is not the case. In fact, we want those signs taken away, and we want to encourage anybody who witnesses a cardiac arrest event and is in that situation to get the AED and use it, because this is probably the most important thing to shock them out of that abnormal heart rhythm that we saw in that second or third slide that demonstrated cardiac arrest. So AEDs are super important. And when it comes to schools and places that we spend a lot of time, ensuring that AEDs exist and are there and are up to date and there's good signage is really, really important. A few comments. Right now, state laws for CPR, roughly 41 states require some type of CPR education for students before high school. These are often unfunded mandates that what constitutes education in CPR really varies. There's a lot of work being done at state and local levels in particular to try to encourage and make these better so that we can, train what the AHA calls a nation of lifesavers and get young people just to have this be second nature. Same for AEDs. And in general, it varies throughout the country. 23 states have some AED legislation. Pennsylvania has one now. This is a little bit older. So they've made strides into the good side about that. The requirements for where these AEDs are really vary by state. So again, things that are being thought about and worked on by many of us who sort of think about this and really want to make this better. Last year, the Health Education Awareness Research and Training in Schools Act was signed into law by President Biden on December 26th. This had bipartisan support. This was a fantastic move forward in that direction. At the time, it was a federal grant program to help schools secure resources needed to implement these measures, such as accessing AEDs, CPR training, developing emergency response plans. And, we are continuing to build off of that momentum. And this was a big win. And we hope to continue to work more on that. The organizations that I would suggest, and there's many of them, but Project Adam in particular is one that was born out of the unfortunate early death of a boy, Adam Lemmel, in Wisconsin, who had cardiac arrest event playing basketball, and his father teamed up with some pediatric cardiologists at the University of Wisconsin, and this program still survives today and it thrives. There's about over 40 different affiliation hospitals, all big children's hospitals throughout the country, and Nemours is one in about 40 states. That work to go into their region, into the schools, and make sure these plans are enacted and that schools have that same response that Damar Hamlin had. We work so closely with the AHA and with organizations like Parent Heart Watch, where really the leadership there are individuals who've been touched by sudden cardiac arrest in their children or loved ones as well, it's a community with a lot of passion and a lot of energy to do the right thing for our kids. And so I would say AHA, Project Adam, and Parent Heart Watch are great places to go if you're interested in learning more, and particularly about your children's school, or to make yourself more prepared. Really quick, in Delaware right now, we're also working on a research study looking at cardiac emergency response preparedness in all of the schools throughout the state to try to get an understanding of sort of where are there gaps, where are there barriers, how can we help the schools that have low resources to have that same response as the schools that have eight AEDs and and all the training in the world. And so we are already in talks to make this particular research project one that is done nationwide, so that we can get that sort of general sense of where we stand as a country and in individual states in terms of our preparedness, with the goal of obviously getting all of these schools to be prepared. So moving on, I think I see we have about 10, 12 minutes left. Pivoting to an entirely different subject here. Before, when we talked about heart health, we were talking about safety and preparedness from cardiac arrest events effectively. A really important component of heart health in the majority of our kids, and ones that I think has to resonate with anybody here, is the idea of how do we keep our kids' hearts healthy and as we deliver them through adulthood, and what does that really mean? And I think, to boil it down, it really means life's essential 8. These are the 8 health factors and health behaviors that we can monitor and modify and focus on and change over time, that are the factors that help keep us alive for a long period of time. I think when it comes to risk for things like heart attack, this is getting more on the idea of heart attacks later in life. If maintaining these levels of ideal levels of each of these factors is what keeps us healthy, and collectively these have been called, again, life's essential 8, and the idea here is that this is cardiovascular health, that we are all born with ideal cardiovascular health effectively, and that unfortunately over time this begins to wane, but we want to promote and keep ideal metrics as long as we can. And I couldn't help myself but to add a few sort of medical-y slides from the journals to kind of hammer home this point. Bear with me here. The gist of it is we'll get to the adjusted cumulative incidence. This basically means, along the y-axis, the likelihood of having a cardiac or heart attack, right? A heart attack or stroke. And age runs along the x-axis, and it starts at 50. And so for individuals, the blue line, for individuals who have ideal metrics of these life's essential 8 components up through age 50, the risk of having heart attack and stroke in life is effectively abolished, about 5%. Whereas those who have these risk factors, a variation of these risk factors, I'm admittedly not getting into the granular details, but who have more poor metrics when it comes to these cardiovascular health, that heart attack and stroke risk increases exponentially. And as you can tell, there's variations of this in between. So focusing on these 8 particular factors is the key to living a longer and healthier life, particularly when it comes to the heart. And I love this slide. I usually would talk when families are in the office, I'll particularly if it's a teenager and we're talking about this idea of heart attack and stroke risk, for example, maybe because of a family member who had a heart attack. I bring this one up because what this tells us is that your clinical cardiovascular health score, forget that specific term, but generally meaning having a number of these ideal heart or cardiovascular health metrics be perfect, and age. So most of us have really good cardiovascular health when we're in our youth, right? At around 17 is one big inflection point down, and I suppose that has to do with college, right? We leave our parents' house and we go off, and our diet might not be as good. We may not be exercising as much as we had done before. Who knows what exactly else is going on? But these are certainly some of the things that lead to that cardiovascular health beginning to decline. And then again around 37, not quite as big of an inflection point, but one in which I imagine is due to, and I can think about this in my own life, kids, busy job, some of these things that we would have focused on and had as ideal when we were younger begin to take their toll a little bit. And this is when our CVH begins to kind of drop. One final graph, and then we'll move on to some of the specifics of life's essential 8. A general concept about life, right? Recognizing that heart attack and stroke are really the number one cause of death and morbidity, is that this idea of normative aging, right? So your health, so if you have a perfect health is up here and your age is down on the x-axis. And so sort of as our life goes on, our health declines gradually and slowly, and ultimately, we do die. The ideal thing, and that we would like to promote, and as pediatricians, this should be first and foremost in our mind, and as parents as well, is that we want to give our children all of the things that we can to have them live a healthy life as long as they can, till as far down in their life as they can, and have a much more compressed period of time where their health isn't as great. And so this concept of squaring the curve was put forth by some of my mentors in fellowship training. I think it's just an awesome way to think about life, right? And about health and life and what we want for ourselves and for our kids. And so we want to square the curve and we want to live a healthy life as long as we can. These 8 factors I put out before, I hope that you spend some time maybe on the Life's Essential 8 website or look into this a little bit more. Some of these I'm sure you're aware of, but let's talk briefly about some of them. Diet is one where I think in the office, when I talk to families, you could spend a lot of time talking about a family's diet. And we recognize that there are so many factors and things that influence our kids' dietary choices. Usually, in my mind, this is about identifying the few things, the 1 or 2 things where we can find improvement. Whether that's sugary drinks and beverages, ultra processed foods, which are certainly talked about a lot these days, and thinking about ways that we can, identify them and the families can identify them and maybe make small incremental changes over time to work towards what ultimately is an ideal dietary factor, right? And so this is admittedly one of the 2 ones in which us in the United States as adolescents generally do pretty poorly in. But balance is key. Sleep. This was the newest health factor added to the cardiovascular health definition that really was started in 2010. It was called Life Simple 7. We recognized how important sleep is, particularly to heart health, and it was now added as one. So I think when I talk to families about heart health, in particular and sleep, which is also one I think that many, particularly adolescents, have a hard time on, so much of it comes down to the phone. And I think that there's good data that suggests that having the phone even in the room affects the psychology of sleep. And so putting it in your shoe, in your closet isn't even good enough. And getting it out of the room entirely is the ideal, better way to go about it. But sleep hygiene is really an important concept and one in which we think about. This is challenging too, because there's so many constraints on, particularly our teenagers and life and school. And how do we get 8 to 10 hours of sleep? We really need to think about this and recognizing it as an important component of heart health, not just, certainly mental health is huge for this as well, but that it has effects on blood pressure and obesity in children and teenagers. Nicotine exposure, fortunately, this is less of an issue these days and for many kids than it was certainly decades ago, but vaping is as bad as smoking and secondhand smoke, right? These are all things we want to avoid. I want to take a moment on cholesterol. I think this is when I always kind of think back on, and as a kid myself, growing up in the 80s and 90s, nobody was checking my cholesterol. This started in 2011, where every kid aged 9 to 11 and again at 17 to 21 should be screened for cholesterol disorders. 1 in 250 individuals have a genetic form of high cholesterol called familial hypercholesterolemia. And you can't tell, you don't feel your cholesterol, it doesn't hurt. Your family history may not be enough to kind of drive screening or testing for this. So it really, if your child is around those ages and hasn't had their cholesterol checked, that would be something to bring to your pediatrician and say, can we get my child's cholesterol checked? Because this is a really important thing to understand, because high cholesterol certainly contributes to atherosclerosis, which is the main sort of precursor to heart attacks later in life. And so we can treat this. And so this is really important to understand. Other things like eating healthy, being active, and drinking water is great. But if you have that genetic form of high cholesterol, those don't move the needle enough most often of the times. And usually kids who have that, depending on how high their cholesterol is, benefit the most from medication that helps lower it. But it dramatically impacts their likelihood of having things like heart attack and strokes later in life. Blood sugar, this is another component of Life's Essential 8. And we think about this as being diabetes. I think a lot of this in my clinical realm is considering it in individuals most often who have obesity or sedentary lifestyles, maybe have high blood pressure as well. And we're worried about things like type 2 diabetes. And so we need to screen for this in certain instances as well and recognize that this is definitely a risk factor and something that can be treated down the line. Blood pressure, I think this is another one where I think, just remember maybe sitting at Thanksgiving with your family when you were younger and the grandparents are talking about blood pressure medications and cholesterol, and you're like, what does this have to do with anything? This is important to kids as well. And 5% at least have confirmed hypertension, and this is ultimately an underestimate as well. children and youth can have high blood pressure, and we need to know about it and treat it. Blood pressure should be checked at all well child visits in kids 3 years and older. And there are certain things that can contribute to it, such as obesity, poor sleep, diet, lack of exercise. Body mass index is still the tool that we use and what we look at to kind of consider like our balanced body and our weight and how that affects our cardiovascular health. I think that we're coming up with better metrics to kind of use and to measure this. I think this is an important kind of thing to continue to work on. So we talk about eating mindfully, being active, getting 60 minutes a day of physical activity, thinking about my plate and all these other things that are important for dietary reasons. And in certain instances where children have severe obesity related to extremely high BMIs, we consider some of the alternatives beyond just behavioral sort of interventions and lifestyle changes. So this is Life's Essential 8. I'm kind of leaving you at that. I think we're just about out of time. This QR code here, if you were to use that on your phone, or if you were to Google or look up Life's Essential 8, will give you so much information on this. And again, these 8 components are what constitute heart health and cardiovascular health in kids that we want to promote and continue through life. So to me, heart health means prevention, which is screening and visits and understanding of your child and the symptoms that they may or may not be having. Preparedness and preparing ultimately and very specifically in my world for things like cardiac arrest, right? And by educating and making sure that our schools and youth sports fields and things like that are prepared for if and when these events happen. And finally, Life's Essential 8. So to me, heart health is prevention, preparedness, and Life's Essential 8. With that, I'll take any questions. And again, I appreciate having the opportunity to come and get into your community and talk a little bit about all this.
Thank you, Dr. Connolly. What a great presentation. We have several questions. We might as well kick it off with the first one, and that is resting heart rate for children. Some of the parents are concerned that their children are playing after school sports. They're playing these sports that are going from homework stationary to right into it. What is that resting heart rate that they should be at, and then what should they be kind of looking at in terms of that exceeding that maximum amount? Like, what is that range?
So your resting heart rate in the majority, or again, going back to that one of those early slides about what constitutes a normal electrical conduction system signal from the top to the bottom, that resting heart rate can vary based on so many things. There is hard to give a specific number. It varies by age. I think in adults, for the most part, and probably in older teenagers, we usually think somewhere around 60 to 100, but certainly, and if you're an athlete or someone who's active, that resting heart rate might be much lower. If you were to be into marathon running or ultra marathon running and see these individuals, they're as healthy as could be. Their resting heart rates sometimes are in the 20s and 30s, and some of this is, and this is okay. I think that maybe as a general rule, what we're trying to define and distinguish as clinicians is when a parent or family comes and they're worried about a heart rate, my job is to distinguish between what's normal and maybe sort of in or around that variability that exists in heart rates, and what is a true arrhythmia. So not the one that we saw, not necessarily ventricular fibrillation, but one in which the heartbeat can go super fast down a pathway that isn't really supposed to be there. And so I think that's what parents usually are thinking about. I think you could say in young children, certainly above 215 to 220 is where we might see these heart rhythms that are called SVT or supraventricular tachycardia. I hesitate to give that number too much more. I think that when athletes or people who are running or active, they can get their heart rates up to 180, 190, 200, and that's okay. I think I would base it a lot more on symptoms. And are you feeling your heart rate fluttering? Are you feeling it being, racing kind of out of nowhere when you're otherwise, not doing anything, and it feels really funny and kind of awkward. But these are the things that are tricky, and they were usually the best way to detect that and to diagnose it is to wear a Holter monitor. And
is there a rule of thumb when it comes to how much exercising is too much for kids?
I've never heard it. Never heard of it. I think it's great. Let's do it. I mean, you got to balance in life, right? But if you're getting your schoolwork done and you're sleeping your 8 8 to 10 hours and you're telling your family you love them every once in a while, then you can be out and exercising as much as you like. There really isn't. Not from a heart perspective.
Thank you for that. Next question was, we're seeing a rise of kids who come to camp with some type of anxiety medication. So that statistic is now increasing more and more. Is that a sign for parents who may have their child on some type of medication that they should also just keep in mind, keep that on their radar, that there could be some challenges that with their arrhythmia or anything on the heart side? This was a great question from a parent who has a child on medication for anxiety. And
Yeah, that's a great question. I think that is a very common clinical reason why I may be involved in seeing a child or a teenager. I think that certainly when it comes to specifics, this is a great question to talk to this pediatrician and psychologist about, or psychiatrist who's prescribing it. Different medications may have different effects and on different kids and in different situations. So it's really hard to make a general rule of thumb. I will say that there is a lot of data on these medications are not uncommon. When we think about anti-anxiety medications and also ADHD medications. And for the overwhelming majority of the time, these don't promote arrhythmias if an arrhythmia doesn't exist underneath, right? So these are generally thought to be safe medications when it comes to heart rhythms or promoting heart rhythm abnormalities. But I think that there's a lot of overlap between the symptoms of feeling your heart beating fast, feeling it flutter, feeling it skip beats, and the symptoms of anxiety. And I think that's where we often are spending time seeing families to kind of try to better understand if their child is having an arrhythmia or if this is really just that, this idea of palpitations and feeling that heart beating and being attuned to so much of your body, which can be a good thing and it can be a bad thing.
Thank you on that. Another question about diet from a parent who basically is saying, children grow up where parents are constantly trying to tell them what's the right thing to eat. They tend to go more towards the fried foods and the sugars, like the candies. How do you strip that from the diet, and how do you help kids grow up healthy without, because you're talking about health behaviors in that essential 8. Any tips?
Yep. Tips. Okay. Tips. Boy, if I had, we could have everyone who's on the call put it in the chat. That would be great. We could maybe write a paper on this. It's not easy. There's no doubt about it. Again, I think that when I meet with families to talk about this to some extent, I usually identify one or two things that seem like the low-hanging fruit, for lack of a better term or a bad pun, in thinking about what small incremental behavior change. And I have a 6-year-old and a 3.5-year-old. It is super challenging, and we're focusing and thinking about it all the time. We are probably losing the battle. I'm not going to lie. Like, it feels like we are all the time. But if we can get that one, that one extra fruit in the day, or find the vegetable that they like, or continue to allow them to try it, despite, them maybe not going full force and eating it all, we take that as a win and we move on and maybe not focus on it, as much, because it definitely, you worry about the psychological impact that kind of comes back to haunt you later if you've just sort of made this the focus of every dinner. I think, again, a couple of the things that, because it's hard, again, I think there's forces out beyond us that are playing into effect, so we can do what we can do in our home. And I think preparing foods, if we have the luxury and ability to do that, is just far and away better than takeout food. That's one way I think that you can kind of identify. If I'm eating out 3 or 4 times a week, how can we lower that to 1 to 2 times a week? If you can do that, that's a big win. If you can eliminate sugary beverages, period, awesome win.
Yeah, fantastic. Two more questions, if it's okay.
Yeah.
It was BMI, that percentage of body weight. What is a safe percentage of body weight for youth today that we as parents should be looking at?
So Like most things in pediatrics, what is considered normal and abnormal is based on percentiles for based on your gender and your height and weight, right? And so there isn't necessarily an absolute body mass index number that I would say is the one that you got to follow and worry about, right? So I think, not to just skirt it, but this is the kind of thing that you have to look at when you go to your pediatrician, and usually they give you some after visit thing that, or while you're there, say, hey, how's my child's, can we look at that growth curve? Because you really want to look at it in terms of your percentile. And so anything above the 95th percentile or below the 5th percentile is considered abnormal. When we're living in between, then we're generally within standard deviations of each other, and that's okay. I think that overweight is usually considered 85th percentile or above, and you sort of obese at 90, and sort of as you go up the line, you're sort of getting into different levels of obesity. But again, it's percentiles in children less than 18 more than it is an absolute BMI number like it is in adults.
Great, thank you. Last question: sleep hygiene. Parents wanting to know whether it's okay to put a sleep monitor on them, or to watch and track the sleep, or just try to do those 10 to 12 hours once they hit the sheets, and once they wake up, just don't worry about the monitors. Or what's your recommendation on that?
Oh, I mean, I think that in general, these are all tricky, right? These life essential aid are not easy. This is the problem, especially the health behavioral parts of it, the factors, the blood pressure, the cholesterol. We can treat those. That seems a lot easier. These concepts are much harder, and the reality is, I think to answer the question, I don't think there's ever a need to be that granular with the data and to monitor and know specifically how many hours your child has slept. I think the big picture is what's important, and promoting sort of the right habits when it comes to this. I think sleep is such a habitual process, and one in which those who are able to do it and able to do it well certainly hope to feel better in the morning and can think better when they're at school and make better choices when it comes to eating and things like that, and exercise. And how you get there is just tends to be such a personal sort of journey. But I think a couple things about sleep hygiene: routine is so important. Going to bed at the same time, waking up around the same time, regardless of the day of the week it is or what's kind of going on. When it comes to things like electronics, lowering these in the first hour, the hours or before you go to bed, is really, really important as well. And again, I think getting the phone and keeping it out of the room. Buy one of those old school like alarm clocks, and they work just as well. And there really isn't a need. Even silencing the phone and having it, again, in your shoe in the closet still has a psychological impact on your sleep quality. And so I think routine, habit, trying to build these and maintain it at a younger age if you can, recognizing that things change as our kids get older, and there's always things you have to adjust, and just be ready for it. But it's not easy. Not gonna pretend like it is, but these are just important factors. And you realize, and maybe you hope, that if you've tried some of these things and done them the right way, that whether or not it's not working 1 month, it might pick up and become something that your child decides is important to him or her later in life.
Dr. Connolly, we can't thank you enough. You have been an outstanding special guest and subject matter expert. I would encourage everyone who is part of this webinar tonight to go on two important websites, and we have a few other references. One is the nemours.org website, as well as the kidshealth.org website. They have all the best suggestions, recommendations, case studies to get all the great recommendations from the great folks at Nemours. And then also, Dr. Connolly suggested a few other groups that have been hyper-focused on the cardiology part of youth development. And that one was Project Adam, which you can find at www.projectadam.com. and then the Project Heart Watch, which is parent the heart. I'm sorry, parentheartwatch.org. And then the American Heart Association is at cpr.heart.org for all those essential key places for references. We'll send that around in our presentation. But again, Dr. Sean Connolly, we want to thank you for your time tonight. Thank you all for tuning in for another incredible Nemours webinar with ESF. And we wish you a wonderful evening. And thanks again, Dr. Connolly, for joining us.
Thank you so much. I appreciate it. It was fun. Take care.
Have a great night. Thank you, everybody. Take care.